Hello everybody and welcome to the Tuesday edition of Video Clips. First of all, as usual, I'll start with a couple of announcements. Don't forget, we have another week or so left of the 2-for-1 Food Over Medicine course if you've wanted to take it. This is an opportunity for you to give a gift to a friend or for both of you to take the course half price. So you can email me about that. The second thing is don't forget our free trial membership. If you're not really sure, you've been watching these video clips for a long time and thinking, I don't know if I want to join or not, why don't you let us give you a free membership and then you can check it out first. All right. Third thing, family health. We've created this new package of courses for people who are saying, look, I don't want to be in the healthcare business. I don't want to become a dietitian or a nutritionist or anything like that. I just would like to be able to help my family and friends and know a lot about women's health, men's health, children's health, that kind of thing. So we have a brand new package. Send me an email and I'll get you information about that. The Diet Lifestyle Intervention course starts in just 3.5 weeks. And that is the program that is approved for CEs for nurses and dietitians and CMEs for doctors. And we have some special packages where you can take a couple of our certification courses at a discount. So lots of packages, lots of things going on. And as usual, I'll remind you, if you are thinking of a career in health or you would like to be doing something with diet and lifestyle intervention, talk to me, send me an email. We'll set up a time to talk. I can share with you what I know about it. We don't pretend to know everything here, but we have been at this for a really long time. We've helped people in 35 different countries to get educated about what good health is all about. So I can share with you our experience and you can evaluate whether or not this is something you want to do. My email address is pampopper@msn.com. All right, so this has been a great week in healthcare because the New York Times featured an article on psychiatric drug withdrawal, and so did Psychiatric Times. Both publications featured information on how difficult it is to withdraw from the drugs. Now, for a very long time, the drug companies and the healthcare professionals have denied that it is so difficult to get off the drugs, but there is no denying it anymore, and I'm hoping that continued public attention to this matter will make it easier for people to find help. So I'll just get started here. I've got a lot of information to share with you on this. In 2014, 1 in 8 Americans over the age of 12 reported recently taking an antidepressant drug. According to the Centers for Disease Control, women are more likely than men to take the drugs, 16.5% of women versus just under 9% of men. The New York Times article said that 15.5 million people have been taking the drugs for at least 5 years. Now, what's the problem with this? The drugs were not approved for long-term use. They were approved for short-term use based on clinical trials that lasted someplace between 2 and 3 months. Guidelines published in 1993 advised doctors only to prescribe the medications for short-term use, 6 to 9 months, in order to help patients deal with the crisis. Well, that's not how they were prescribed at all. The absence of long-term data didn't prevent doctors from prescribing the drugs for a long time. I mean, tens of millions of Americans were placed on the drugs with absolutely no conversation about how they were going to stop taking them or that they ever would stop taking them. The drugs are harmful. They affect sleep habits and appetite, and they cause weight gain, erectile dysfunction, pain, and gastrointestinal symptoms such as nausea. Antidepressants increase both depression and anxiety in some people. My gosh, these are the conditions that they're prescribed to treat. The effect is dose dependent. The more drug you take and the more drugs you take, the higher the doses and the more drugs you take, the more symptoms you'll have and the more severe the symptoms are likely to be. And another thing I think that we should not stop talking about is the fact that the antidepressant drugs do not resolve depression. They generally just make people numb to the way that they feel about life, so no underlying causes are addressed. Perhaps the most important issue regarding antidepressants is that when patients try to stop taking them, many experience what's called Discontinuation Syndrome, or symptoms associated with withdrawal. The symptoms are most likely the result of damage to the central nervous system and brain while taking the drugs, and then the body's attempt to adjust after the dose is reduced or the drugs are withdrawn. Common symptoms include dizziness and nausea, lethargy, headache, anxiety, and agitation. In some cases, these symptoms get to the place where people are almost disabled. They can't function normally or go to work. In many cases, restoring the dose or restarting the drug is required in order to reduce symptoms. While many insist that only 20% of patients experience side effects or withdrawal symptoms, a survey of 250 patients with serious mental illness showed that 74% of the patients decided to stop taking the drugs because the side effects were no longer tolerable. And of those 250, 54% reported that the withdrawal symptoms were severe. Only 45% reported that their prescriber was in any way helpful in the process. Another study reported that almost half of patients said that they felt that they were addicted to the drugs. In spite of this, there really isn't very much research on withdrawal from antidepressants. Clinical trials are more focused on short-term efficacy rather than any long-term consequences, including withdrawal from the drugs. And the drug companies, let's face it, what incentive do they have to conduct research concerning how to withdraw from the drugs that they sell? Furthermore, the FDA doesn't require them to do such research. One review showed that there are 3 major issues with SSRI, a type of antidepressant withdrawal. The first thing is there is no way to determine which patients will have withdrawal symptoms and how terrible they'll be. Even gradual tapering doesn't prevent severe withdrawal symptoms. Withdrawal seems to cause many additional psychological complications such as hypomania, mania, and other disorders. So this is just not as easy to do as people were told or led to believe. Doctors prescribed psychiatric drugs for decades before it became widely known that withdrawal was a problem. For example, the first benzodiazepine was approved in the United States in 1960, but it wasn't until the 1980s that doctors recognized that benzos were difficult to stop even when the patient tapered very, very slowly. Challenges of benzodiazepine withdrawal include the fact that severe withdrawal symptoms do not always go away when the doses are restored or medication is restarted. Withdrawal symptoms can last for several years, and severe reactions can happen even when the patient very carefully and very slowly tapers the dose to the place where it can take several months or even several years to withdraw. Originally, withdrawals from SSRIs were presented as being not serious and easy to treat, but eventually research showed that SSRIs are just as addictive as the benzodiazepines and just as difficult to withdraw from. Yet still today, the FDA allows the label on Cymbalta to state that side effects related to withdrawal are only experienced by 1% of users, which is significantly different than the data I've been sharing with you in this video clip. Many doctors say that the severity of withdrawal symptoms depends upon the half-life of the drug. So SSRIs with a short half-life, like Effexor or Paxil, are much more difficult to withdraw from than drugs with longer half-life, for example, Prozac. But a recent long-term study of withdrawal showed that this is not necessarily the case. This study included 250 patients who had taken Prozac for a considerable time, who were randomly assigned to 2 groups. Half of the patients were tapered slowly, receiving a capsule with lower and lower amounts of the drug for a month or longer. The other half was given a drug. They were told they were tapering, but they were given the full dose of the drug. The patients were followed for 18 months, which is a reasonable time. In spite of Prozac's long half-life, some patients had withdrawal symptoms that were so severe that they had to go back to taking the drug or be restored to their previous dose. Well, as a result of all of this, doctors don't necessarily know how to, they're very good at putting people on the drugs, not necessarily very good at knowing much about how to take them off. Patients are turning to each other for assistance, and as you might imagine, the internet has offered a lot of opportunities for people to congregate. The front page of Psychiatric Times, the article I mentioned earlier, featured an article about online communities that have formed to offer support for people withdrawing from the drugs. The article reports that one site for patients taking benzodiazepines who were trying to withdraw receives an average of 250,000 visits per month, while another, called survivingantidepressants.org, receives about 150,000 visits per month. The author states that the sites are providing data that's being watched and used by the medical community to learn more about, quote, unexpectedly difficult withdrawal symptoms and syndromes. The author also writes that the forums and online testimonials reveal that doctors are unprepared and have no idea how to help patients withdraw. The scope of this problem is really difficult to fathom. Almost 25% of Americans today are taking some form of psychiatric drug, and many people take more than one or several. Prescribers are not often helpful, and sometimes they are downright hostile when patients say they want to begin withdrawals, which means that the patients are left on their own to try to figure this out, and I don't think that's an ideal circumstance. To my knowledge, our program, Why and How to Withdraw from Psychiatric Drugs, is the only formal education program that prepares practitioners to deal with this issue. And we're hoping that tens of millions of people at some point in time take this course, or tens of thousands of people take the course so that they can help the tens of millions of people who need assistance. And when I talk about people taking this course, I'm talking about prescribers, psychiatrists, family practice doctors and internists, and counselors and clergy, anybody who might be trying to help patients who are taking the drugs, because withdrawing is not an easy thing to do. I know that we talk to members all the time who are going through this process, and of course the first thing that many of them will say is, had I known then that it was going to be so difficult to stop these drugs, I never would have taken them. And so this goes to the importance of informed consent discussions that we talk about here all the time, that people should know before they make a choice what they're really getting themselves into. But furthermore, what people tell us often is that when they try to talk to their doctors don't know anything about how to withdraw. Their psychiatrists are sometimes, as I mentioned, downright hostile to the idea. And so patients really are on their own. So we're going to run our course again the end of the summer, beginning fall this year, so you have plenty of time to find out about it. And if that's something that interests you, also send me an email at pampopper@msn.com. I really think that something that is as dramatic as affecting 25% of the population in our country deserves a lot of attention and effort, and we hope that you'll help us solve the problem. All right, that's all for today. As usual, pass this on to anybody who you think would enjoy watching it, and I'll be back to you on Thursday with more news.